Good evening, everyone. Thank you for joining us this evening. The topic for discussion this evening is emerging burden of leptospirosis in the context of COVID pandemic. This session has been organized by the Sri Lanka College of Internal Medicine and presented to you by Dr. Reddy. Moderating the panel this evening is Dr. GANAKA SENARATNE, consultant physician, emergency treatment unit, the teaching hospital at Karapitiya. Dr. GANAKA, good evening and over to you, sir.
Hello, thank you, Anton. Good evening to all of you. I'm GANAKA SENARATNE, the editor of Sri Lanka College of Internal Medicine. It's my pleasure to welcome all of you for this webinar on this leptospirosis tonight. As healthcare professionals, we have been battling with the COVID-19 for about last 2 months and were able to achieve some control over the epidemic, limiting the number of deaths to 10 so far with a mortality rate of 0.7%. Every institute involved, every institution, agency involved, including government, Ministry of Health, security forces, professional bodies, worked really hard to achieve this success. So as Sri Lanka College of Internal Medicine, we were able to amply support the Ministry of Health through our delegations representing various advisory committees established to combat the epidemic and drafting few important protocols such as on treatment aspects and exit plan for hospitals. We were able to empower our members working all over the country with the new knowledge needed to manage these patients by having few webinars. If I am to mention few of them to you, first we did clinical management of COVID-19 patients with Dr. Ananda Vijayavikrama, and then diagnostics of COVID-19 patients with Prof. Neelika Malavige, moving to epidemiological aspects and exit strategy with Professor Kamani Mendis. And we were able to educate the public and healthcare workers via few TV programs and small video clips circulated in the social media. An online learning module for healthcare workers were arranged with the collaboration of University of Colombo and Ceylon College of Physicians. As such, Sri Lanka College of Internal Medicine itself and all our member physicians all over the country have been very busy last few months arranging all the care needed for those patients of COVID-19 from admission to discharge with the help of our colleagues. However, with the return of rainy season, the council was informed by our members all over the country that the leptospirosis is emerging again. All of us know that how bad lepto could be, as it causes pulmonary hemorrhages, acute renal impairment, sepsis, myocarditis, and multi-organ dysfunction. It's very clear that it has extremely higher mortality and morbidity than COVID-19 infection in Sri Lanka when it causes such complications. Therefore, the President and the Council of Sri Lanka College of Internal Medicine felt that it's high time to revisit this deadly infection in order to prepare and regroup ourselves to fight against this alongside the ongoing COVID battle and ensure all our lepto patients to receive best possible care. That is why we all have gathered here for this webinar tonight. Emerging burden of leptospirosis in the context of COVID pandemic. Ladies and gentlemen, we have three eminent clinicians who have been doing a lot of work and researches in the field of leptospirosis to talk to us today. Let me introduce each of them for the audience. First, it would be Dr. Panduwa Karunanayaka, specialist physician at National Hospital in Sri Lanka and a senior lecturer in clinical medicine attached to Colombo Medical Faculty. Hello, sir. Good evening. Good evening to you.
Good evening.
Next, we have Dr. Lilani Karunanayaka. She's the consultant clinical microbiologist and head of the National Reference Laboratory for Leptospirosis of Medical Research Institute, Colombo. Hello, madam. Good evening.
Good evening to everyone.
Then third panelist is Dr. Vimalsiri Uluwathage, Senior Consultant Physician attached to Teaching Hospital, Karapitiya. Good evening to you, sir.
Good evening. Good evening, everybody.
Dear sir and madam, on behalf of the President and Council of Sri Lanka College of Internal Medicine, it's my great honor and pleasure to welcome all of you for this webinar. Thank you so much for joining in. Before we start, I will voice out the housekeeping rules of the day for our convenience. So this is going to be 1 hour. There will be 3 presentations, 15 minutes each. Questions will be taken at the end. So speakers, each of you will speak for 15 minutes. Participants, please keep your mics muted and please keep your phones in the silent mode. You can text questions at any time. You can use the chat option in your software and we will sort them out and then taken up at the end of all 3 presentations. We will try our best to answer all the possible questions. Ladies and gentlemen, we are good to start now. May I invite Dr. Pandu Karunanayaka to kickstart the webinar. He'll be talking on epidemiology, presentation, and initial management of leptospirosis. Over to you, sir.
Thank you, GANAKA. Thanks for the introduction, and let me start by also thanking the Sri Lanka College of Internal Medicine for giving me this chance to present these facts before our audience. So I've been given the task of talking about 3 things: epidemiology, the initial presentation, and initial management of leptospirosis. So I'll start off with the epidemiology. Let me just recapitulate it to start with. As we all know, leptospirosis is a zoonosis. That means there is no human-to-human transmission. The natural reservoir of the pathogen is a wide variety of mammals who carry the pathogen in their kidneys. The ones that are important in Sri Lanka itself are the rat, the water buffalo, cattle, and dog. So because of this wide spread of the natural reservoir, it is not possible to eradicate the infection. All we can do is prevent it as much as possible. And from this natural reservoir, from these kidneys, the pathogen is excreted into the environment in their urine. And the pathogen survives in stagnant, slightly alkaline waters without saline, without salt. That's why basically, for example, it is not found in seawater. So there are 2 modes of transmission of leptospirosis to human beings. One is the direct transmission, that is from the animal tissues or from urine. Human beings are directly exposed. This happens, for example, in occupations like abattoir workers, butchers, veterinarians, and dairy farmers. And the other is indirect transmission, where the humans are exposed to the stagnant water which has been contaminated by the animal urine. This occurs, for example, in certain occupations such as farmers, sewage or drainage workers, armed forces, gem miners, and so on. And also it can occur due to various environmental exposures. For example, part-time farm workers, if you ask them what their job is, they might say that they are drivers or something, but in fact they may be also part-time farm workers. Ecotourism, hiking and camping in jungles and the wild, and also children who play in paddy fields or marshy lands during the school vacation. That also is a reason, way of exposing themselves. With regard to leptospirosis in Sri Lanka, it's a notifiable disease. And if you look at the whole national incidence of leptospirosis, we have an annual incidence which is always more than 10 per 100,000 population, which is a very common infection. And the highest incidence occurs from May to November every year. And if you look at the case fatality rate, the overall national level varies between 1.5 and 2.9% from year to year. So that's a very high rate. But in teaching hospitals, various teaching hospitals, which get complicated cases, it is much higher. For example, at Karapitiya, it was 28.1%. There is a current outbreak going on now as well because it's the month of May, and rather, May is almost finishing now. And the current outbreak was seen in Ratnapur and Kagalle, and also Kalutara, and Gaul, Matra, and Hambantara. Although it's possible that the reason why we have this outbreak in Hambantara and Matra, which are new areas, maybe because of increased awareness, because I do know that my colleague Dr. Udvattage has been conducting a lot of awareness programs in Matra and so on. We actually looked at the geographical distribution of confirmed cases of leptospirosis at the MRI in 2016, and basically what we found is that the distribution is fairly uniform. I mean, if you look at that list on the right-hand side of the slide, you can see that the Western province has 69%. That's because of a referral bias, because the MRIs in the Western province, we get more samples from the Western province. But the rest of it is basically very similar. So it's fair to say that it is found in just about every province in the country. The all-important epidemiological history, which we often use for diagnosis, there is no leptospirosis without an exposure. However, the exposure may be so subtle that it is often not recalled at the presentation of the patient. And it occurs increasingly in unusual occupations. So that is the story shifting from an occupation-related story to an environment-related story. And also it occurs increasingly in the urban setting. So it's also changing from a rural disease to an urban disease. So I'll tell you two case stories which are real that I myself saw. There was one patient who living in Colombo, a banker, who got leptospirosis confirmed microbiologically, but couldn't recall an exposure. But when he came for the convalescence sample test report, he had remembered how he got exposed. He said that this was time of flooding in Colombo, and the Sri Lanka Tennis Association courts, which are near the public library, was flooded. One of the courts was flooded. And basically, after work, he came home, changed into a pair of shorts and t-shirt and slippers, and went to pick up his daughter, who has been at practices at the SLTA post. And he had to wade through the water in one court, near which there was a garbage dump, and the water had washed the garbage onto the courts. So he went in and picked up the daughter and came back, and on the way back also he waded through, but the daughter was wearing tennis shoes. So he got the infection and she didn't. Then there was another case that we saw a schoolboy. On close questioning, we just could not find out what the exposure was. But again, during the convalescent report collection, when the mother came, she said that even finally the teacher realized that what has happened was that the schoolboy has helped the teacher along with some other children in the class to clean the environment of the school. And that was also rat infested because there were rats that were found. So it can be very subtle, and it won't be volunteered by the patient on presentation, but it can be recalled by the patient or the family later on. So the epidemiological history is changing from rural to urban, from occupational exposure to environmental exposure. So we can't be satisfied just by asking what the patient's occupation is. We must go on and ask what environments the patient has been exposed to. For example, stagnant waters, rat-infested urban environments, exposure to the wild, and so on. And it's also changing from a seasonal to an endemic condition. So if I talk about the presentation of the disease, I'll start off with another case. This is a 42-year-old garbage collector who was admitted to a base hospital on day 3 with an acute febrile illness, or an AFI. From day 3 to day 6, he was managed in the base hospital as a case of dengue fever and alcohol withdrawal, and the chest X-ray which was done at that time was unremarkable. But on day 6, he became breathless with dropping saturation, and the chest X-ray was repeated, and they also found that the serum creatinine was by now elevated. So I can show you the two chest X-rays of this patient, the initial one as well as the one that was done on day 6. You can see that the initial one is normal, but that the second one you can pick out the cotton wool with the soft opacities, which are also becoming gradually confluent. So rapidly progressive chest X-ray changes in an acute febrile illness. What's our differential diagnosis? We must think about leptospirosis and also Hunter-Weiss pulmonary syndrome, and in fact the two can coexist as co-infections as well. It can also be melioidosis, or community-acquired pneumonias with ARDS, including due to influenza and COVID-19. And also, of course, acute febrile illness with a missed myocardial infarction and left ventricular failure. So this chest X-ray, which is fairly early in this picture, can progress to something like this, which is very obvious. This right-hand side one was not our patient, but I thought I'll show you that X-ray to show you how bad it can become. So if you find an abnormal chest X-ray progression like this in leptospirosis, the typical finding is it starts off as alveolar consolidation, mainly in the peripheries in any zone, but becomes rapidly progressive to become film-fluent opacities. And the severity is graded according to the number of quadrants involved, but it's never cavitary or lobar distribution. There are three possible pathogenetic mechanisms for this chest X-ray in leptospirosis. The first is leptospirosis pulmonary hemorrhage, or LPH, also called diffuse alveolar hemorrhage. And if that becomes very severe, it's then called severe pulmonary hemorrhage syndrome, or SPHS. The second possible mechanism is acute kidney injury and volume overload. And the third is acute myocarditis, giving rise to left ventricular failure. So our patient himself actually had acute kidney injury, and these are two chest X-rays of his before and after dialysis. You can see that there's marked improvement on the right-hand side. So why is leptospirosis so difficult to pick out clinically? Now, our traditional teaching is that there are non-specific clinical features and typical or expected clinical features. Non-specific ones are fever, chills, and headache, and the typical expected features are severe myalgia and frustration, conjunctival injection, suffocation, and hemorrhage in the eyes, along with jaundice, neutrophil leukocytosis, and the occupational history. Even for this particular typical presentation, there's a wide differential diagnosis, which I have shown on the right-hand side. But the first reason that why we miss leptospirosis is that we don't often get this typical picture or typical features. And then the differential diagnosis no longer includes leptospirosis in our minds because of our traditional teaching. Instead, what you have sometimes is that you have various misleading features of leptospirosis, which leads us to think of some other condition, such as, for example, if there's dry cough and hemoptysis and lung signs and desaturation and chest X-ray infiltrates, we begin to think of community-acquired pneumonia or hantavirus pulmonary disease or melioidosis. If there's photophobia, neck stiffness, delirium, or alcohol withdrawal seizures, we start thinking of CNS infections and typhus. If there's nausea, vomiting, diarrhea, abdominal pain, elevated serum amylase or lipase, and acute pancreatic features, we start thinking of a surgical acute abdomen, including pancreatitis. If you find dehydration, hypotension, and oliguria, we think of community-acquired sepsis or dengue. If we find there's jaundice and elevated transaminases and hyperbilirubinemia, we may think of viral hepatitis, liver abscess, or melioidosis. Sometimes there is pancytopenias or individual cytopenias, and then we think of dengue, malaria, and so on. So all these things that I have listed from 1 to 6 are actually atypical manifestations of leptospirosis. The reason why I say atypical is because they are not the traditional teaching of typical leptospirosis that we have received from our medical faculty days. And these atypical manifestations leads us into thinking of different conditions. So anecdotal leptospirosis without jaundice is very common. In fact, only about 5 to 10% of people with cases of leptospirosis actually have jaundice. So the old teaching was the more severe cases are icteric, but the new reality is that erythroid cases can also be severe or even fatal. When leptospirosis presents as an acute febrile illness without jaundice or the epidemiological history, it is easily missed, and any complication it produces misleads us into a different diagnosis. So laboratory confirmation has now become very crucial. Leptospirosis is changing its epidemiological picture from rural to urban, occupational to environmental, seasonal to endemic. And also there are unusual manifestations which are appearing more and more. In Sri Lanka especially, we have the pulmonary hemorrhage, myocarditis, pancreatitis, and also community-acquired sepsis. And there can be concomitant infection with other pathogens such as dengue and hantavirus. So for these reasons, laboratory confirmation has now become very crucial for leptospirosis. Let me get on to the initial management questions that we often see. Basically, what is the best antibiotic for leptospirosis? The best evidence from in vivo studies is for benzyl penicillin and third generation cephalosporins. That will be basically benzyl penicillin, cefotaxime, or ceftriaxone. The in vivo evidence is less robust for other antibiotics such as carbapenems, fluoroquinolones, amoxicillin, and coamoxiclav. And oral antibiotics which are used in mild disease as outpatient therapy include doxycycline and azithromycin. So basically, in hospitalized patients, we should probably try to use one of those three first antibiotics I mentioned. If you need broad spectrum cover to cover other pathogens as well, which is a very common situation, do we still need to give basal penicillin? If you are using cefotaxime or ceftriaxone, I think they are fairly safe. But in the case of any other antibiotic, although there may be in vitro evidence, we still don't know for sure whether we have to add basal penicillin to be certain as well. Some people have this habit of using both ceftriaxone and doxycycline in combination, and I don't think there's any reason that that should be done. That's not necessary. And the other question that I would like to answer with regard to initial management is what is the place of glucocorticoids in severe leptospirosis? Well, there were two clinical trials on this. The first one was done in Peradeniya, where they used methylprednisolone intravenously, followed by orally. Here, the cases were diagnosed on clinical, hematological, and biochemical parameters, and the control group was a historical control group. And the conclusion was that methylprednisolone improved survival in those with severe leptospirosis. The second trial was done in Thailand, and there they used a very large dose of dexamethasone intravenous infusion for 3 days, followed by oral prednisolone. Here the cases were confirmed microbiologically. It was a randomized controlled trial, and there was no survival benefit, but there was increased risk of major nosocomial infection, which is not surprising because, as you can see, the dexa dose was pretty high. So I think on the whole, it's fair to say that there's no established place for glucocorticoids. So I think my time is up now. So I just leave this a take-home message for you. Message number one is the epidemiology of leptospirosis is changing. So greater awareness and suspicion are necessary. Earlier it was rural and occupational, but now it's urban and environmental also. The second message is laboratory confirmation has become crucial and it is available. The third message is we need to think of leptospirosis in a wide variety of presentations because of the many atypical presentations and complications. The traditional teaching is no longer enough. And the fourth message is with regard to antibiotics, basal penicillin and third generation cephalosporins are the best ones. And we also need to do more cultures in order to find out about ABST patterns. And the fifth message is there's no proven place for glucocorticoids. Thank you very much. Thanks, GANAKA.
Right. Thank you, Dr. Panduka, for that excellent update on epidemiology and the clinical presentation and initial management of leptospirosis. We'll keep the questions for the end. We are moving for the second talk of the day that will be done by Dr. Lilani Karunanayaka. I would like to invite her for her talk on optimal utilization of laboratory services. Over to you, madam.
Thank you, GANAKA. And good evening to everyone. I would like to thank the President and the Council for inviting me for the important webinar. So tonight I will be talking about how to utilize the laboratory for leptospirosis diagnosis. So the scope of my talk is the available laboratory diagnostic test, overview of laboratory tests, sample collection and transport, and reporting procedures. So these are the available laboratory diagnostics at the National Reference Laboratory. We do direct microscopy, isolation, DNA detection in blood and urine by real-time PCR, then serological test like microscopic agglutination test and ELISA. So I would like to mention two important information that you would need to select the suitable lab test. One thing is that at the time of patient presentation, you need to know whether he is in the acute phase or in the immune phase. Now, acute phase is the leptospiremic phase where you get leptospira in blood, which is which lasts for about 1 week. And in the immune phase, it's called leptospiruria, which starts at day 4 and lasts for about 30 days. So for that, proper history about the onset of fever or any symptom is very important to select the suitable test to support your diagnosis. Moving on to the diagnostic testing, culture is the gold standard and it gives the strongest evidence for confirmation of the diagnosis. So we can identify new strains or associations with clinical entities like pulmonary hemorrhage, then pancreatitis, or we will know the circulating serova in a particular locality or in the country. Also, we will be able to perform antibiotic susceptibility testing, which is very important for the management. We can use these cultures, our own strains, in our microscopic agglutination test, which will give a higher sensitivity. Also, for the epidemiologists, they will know, they can identify the probable animal reservoir, which is very useful in targeted control activities. So, culture isolation. Just focus onto the 4 bottles. What we provide. The uninoculated bottle is the clear colorless bottle, and the next bottle is the inoculated bottle with 2 drops of blood. So after mixing well, it should appear as cherry blossom pink. Now the color is shown just below the cherry blossom flowers. So other 2 bottles has more than 2 to 3 drops of blood, which means leptospira will be inhibited by inhibitory substances in blood. Because in this bottle, there are only 1 to 2 leptospira will be there in the bottle. So these bottles are provided by the National Reference Laboratory. So you can request the bottles from us. That is for blood culture. Also, you can do CSF, but which is very low, which has a very low positive rate. Now, if you want to do the cultures, then the best timing is within the first 5 days. Now, molecular methods have become an important tool for infectious disease diagnosis. Real-time PCR has now replaced the conventional methods. Unlike cultures, PCR test does not require viable organisms. Therefore, RT-PCR, that is what we do, assay is the best diagnostic tool for early illness. Now, they are accurate, they are very fast, you can have very quick results. Also, you can quantify, and contamination is lower than the conventional method and has a higher sensitivity than culture and serology in early disease. So we established RT-PCR in 2017 and it's an in-house validated method. The diagnostic sensitivity of our blood for our blood specimen is 82% and for urine it's 52% with 100% specificity. So you can send a clotted blood or serum or urine. Now whole blood is the best specimen theoretically, that is in EDTA, but in our experience now these whole blood in EDTA should reach our lab within 6 hours or at least within 24 hours, which is not happening here. So we will not be able to give you a accurate result on if the sample collection and transport is not good. So what I think is clotted blood, serum or urine will be the best specimens for especially for outstation hospitals. Coming over to the indirect methods, serology is used best in the immune phase. Now, IgM appear 3 to 7 days after onset of peak and peak at 3 to 4 weeks. 10% may not develop antibodies, and another 10% may develop antibodies after about 1 month. There are two main serological methods. The rapid serological tests like ELISA and ICT, they are used for screening. But if you are using these type of methods, then you have to see whether they are validated before use, due to the geographical strain variations. Microscopic agglutination is the confirmatory test or the serological reference test, and it will identify IgM and IgG, which appear later after around 5 to 7 days. Now, the antibodies differ for ELISA and MAC, and it will persist at low levels for years, and we identify serogroup, and these serogroup specific antibodies are short-lived than the serovar specific antibodies. We have compared 3 serological methods, assuming all 3 are imperfect. Now here there are no gold standard. So if you concentrate on the table, the highest sensitivity is shown by ELISA, and the highest specificity is shown by microscopic agglutination test. So single MET sample will give a very poor sensitivity, that is around 77.4%. Therefore, we can comfortably conclude that rapid tests like ELISA, ICT are suitable only for screening, and MAT should be used for confirmation. Here again, we have compared another 2 different rapid tests. Now we have compared this against MAT, microscopic agglutination test, and there are 3 important messages. One thing is the rapid test again can be used as screening test if you see the table 1. Then the second finding is that according to the figure, the ROC curves for ELISA and ICT, ELISA gives a better agreement with the MAT result than the ICT, that is immunochromatographic testing. And also table 2, the third point is the cross-reactivity. If you could see, the ELISA and ICT will cross-react with dengue positive sera, but not MAT test. So you have to keep these in mind when you are interpreting laboratory results. When you come to microscopic agglutination test, that is the serological reference test, which is used do in a reference laboratory. It's complex, time-consuming, and a very tedious procedure. Why? Because all these strains has to be maintained in culture for the preparation of antigens. So we do in-house preparation of our own antigens. It's a live method we are using. When you are interpreting the result, we have to know the baseline titer in the country. So we have done a study, and we have found out our cutoff, or the optimal cutoff titer is 320 with 90% sensitivity and 99% specificity. Now when actually MAT needs a second sample to confirm diagnosis. Especially if you have sent a early sample in the acute phase, then you need to send the second sample in the immune phase to confirm, because the optimal cutoff is 320. So ideally, second sample should be sent within 10 to 14 days after the first sample, or patients in the ICU or with typical symptoms. Then you can send the second sample in 3 to 7 days. even if that sample is also negative or insignificant, then of course you have to repeat the sample later within 10 to 14 days. So our pathomet panel have 15 serogroups, 14 pathogenic serogroups and 1 saprophytic. And our test is a validated test, and we participate for the external quality assessment program conducted by the International Leptospirosis Society, Sydney, Australia. So knowing about the confirmation of leptospirosis is very important for surveillance and research in addition to clinical management. So there are only 3 tests recommended for confirmation of a clinical case. So they are a positive culture of pathogenic leptospira, positive PCR test for pathogenic leptospira, and a MAC titer for us, for Sri Lanka, is equal or more than 1 in 320, a 4-fold rise, or a seroconversion from acute and convalescent sera. So this is a globally accepted criteria. ELISA is not a test for confirmation. If you do ELISA, that means your patient is a probable patient with leptospirosis. So this is the most important slide in my presentation. This information is critical for you to receive an accurate sample. So if you do a culture, it has to be in the acute phase, fresh blood 2 drops, best before antibiotics, but we have grown even after 2 to 3 days, 2 to 3 doses of antibiotics, and you have to send it in room temperature, and the turnaround time, the results will be only after 1 to 6 weeks. DNA detection, again acute phase, you can send serum, blood or urine, and best in a cool box. Your results will be known in 1 to 2 days. Then MAT, first sample in end of acute phase and second sample in immune phase, again in a cool box. Results will be in 1 to 2 days. Then we do direct microscopy. We do not encourage direct microscopy. We do it for CSF and urine only, and results will be given immediately. So report delivery is the last one slide. Report delivery to the clinician is a challenging task, and presently we try many modes, and few hospitals has their own emails, so we email the results, but we do telephone all significant results in ICU patients. And if you want e-report, then you can send us the email address, but we don't send to patients or relatives. Also postal and fax. So my summary of my talk is time of onset of fever is very important in selecting the test. Short clinical history in the request form is very important. Validated quality control procedures are in place for all tests at the National Reference Laboratory, and culture is very valuable to know our own disease, about the disease in the country, and for the patient management. ELISA ICT is accurate only if it is validated in local setting and useful only for screening. E-based report delivery system is available. Samples are received at MRI 24/7, and if you want more information, you can visit our website, MRI website, for any further guidelines. Thank you very much.
Right. Thank you, madam, for that excellent update on laboratory diagnostics and the practical aspect as well. Let's move on, and participants, you can use option chat for sending in questions at any time. And we are moving to the final talk of the day that will be done by Dr. Vimalsiri Uluwathage, the Senior Consultant Physician, Karapitiya. He will be talking us on changing clinical patterns of leptospirosis and management of severe cases. Over to you, sir.
Thank you, GANAKA. Thank you for inviting us for this webinar. The president and the colleague of Sri Lanka College of Internal Medicine invited us to do this presentation. We are happy about this arrangement, and thank you very much for that. And if I'm going to share my slides with you. Yes, so today my topic changing clinical patterns of leptospirosis and management of severe cases. So this is the map of world map of leptospirosis, and the red indicates that the highest incidence. Now you can see that Sri Lanka is in red, indicate Sri Lanka is a country with highest incidence of leptospirosis. With that in mind, we'll move on to basics. And to start with my talk, I just want to remind the case definition. What is a case of suspected leptospirosis? Because you know that the diagnosis of leptospirosis is difficult and takes time. And for that, when the patient's presents in acute stage, we need a working diagnosis. So that's why we use a case definition to define a suspected case of leptospirosis. So any patient who is coming with acute febrile illness with high risk exposure to contaminated water, together with two of the following signs and symptoms, would be called as a case of suspected leptospirosis. So as Panduka mentioned before, the traditional classification of leptospirosis is ictery, which is the milder form, which is the majority, and the icteric form, which is the severe form, also called Wales syndrome, which is comes with a classic triad with jaundice, renal impairment, and bleeding as it is called Wales syndrome. Now, something different actually observed in 1995 in Nicaragua when they had outbreak. They found a cohort of patients who died of confirmed leptospirosis. The cause of death was not renal or hepatic, but it was severe pulmonary hemorrhage. And they also noticed that those patients, renal or hepatic complications were very minimal. And later on, many other countries also reported the same phenomena. China, Korea, Brazil, and India reported the same thing. So then they call it as a severe pulmonary hemorrhagic syndrome. So that the presentation they describe as a severe pulmonary hemorrhagic syndrome. Actually, Brazil reported, going back to their surveillance data, as you know, Brazil is one of the countries with good surveillance system in place to detect leptospirosis. So going back to their data, they noticed that this condition called severe pulmonary hemorrhagic syndrome is entirely a new phenomenon, right? And they confirmed that this phenomena, or the pulmonary involvement, severe pulmonary involvement in leptospirosis started to manifest in the recent past. So because of that, we call leptospirosis has changing clinical patterns over the course. So now with this knowledge, we can say that we have got two severe forms of leptospirosis causing high mortality. The first is the well-known Wales syndrome, and the second is severe pulmonary hemorrhagic syndrome. Now, how about Sri Lanka? In Sri Lanka, in 2008, in this year, actually, Sri Lanka reported the highest number of leptospirosis recorded in the history. And in 2008, Teaching Hospital Karapitiya reported of 459 cases of leptospirosis. Out of that, there had been 25 fatalities. And out of these 25 fatalities, 21 autopsy had been performed on request. And strange thing is that the cause of all these deaths, of 21 deaths, were due to severe pulmonary hemorrhage. This was reported by our JMO at that time, Dr. Wanpura, in the Medical Journal of Malaysia in 2012. And later on, in 2019, Teaching Hospital Karapitiya, we, study group, we reported more than 100 confirmed cases of pulmonary hemorrhage at Teaching Hospital Karapitiya. So, why SPHS is called a different entity? As you all know that bleeding tendency and respiratory symptoms are not uncommon in leptospirosis because they present with subconjunctival hemorrhage, conjunctival suffusion, and hematuria. So that is the evidence of bleeding tendency. And also they can present with cough and even hemoptysis. So then why this different entity come into picture? Because this SPHS has these features: the minimal renal and hepatic involvement. It is predominant clinical pictures respiratory distress, as opposed to in Wales syndrome, it is renal or hepatic involvement. Here it is predominantly respiratory distress syndrome and associated with very high mortality in ranging from 50 to 70%. In some cases, is much more than that. So that is why we call SPHS is a different entity. So how to recognize severe leptospirosis? Either it's Wales syndrome or SPHS. The hypotension is a very common manifestation in severe cases of leptospirosis. The physicians who have managed these patients remember that most of these patients, just after admission, in the third day or fourth day of the illness, they go into a state like something similar to a state of shock, where they become hypotensive. And in milder form of leptospirosis, you get polyuria, but in severe case of leptospirosis, you get oliguria. And at the same time, hyperkalemia is a sign of severe leptospirosis, whereas hypokalemia is a sign of mild leptospirosis. But with that, how are we going to recognize SPHS? Now, in SPHS, you get these features. They become tachypneic. And on the third day or fourth day, this happens very early in the illness, actually. On the fourth day to sixth day, they develop these features. They become tachypneic. They might develop hemoptysis. And sometimes, and if you have the facility to do ABG, it will show arterial hypoxia. And later on, the chest X-ray would show the evidence that the Panduka discussed earlier. So going on to the chest X-ray, so this is a typical chest X-ray of a patient who suffered severe pulmonary hemorrhagic syndrome. The description of radiological description of this X-ray is small nodular opacities that may progress into large coalescent areas of consolidation. We call it alveolar shadows or cotton wool shadows, which are mainly bilateral and often inferior, and it's distributed peripherally. So if you can do the HRCT, that will mainly show bilateral ground glass opacities. So I told you before that hypotension is a common feature in severe leptospirosis. So now the evidence shows that there is a similarity between bacterial sepsis and severe leptospirosis. According to this paper, this article published very recently in 2019 April, according to this, the severe leptospirosis features in the spleen indicate cellular immunosuppression similar to that found in the septic shock. So their conclusion was severe leptospirosis behave very much like bacterial sepsis during its initial presentation. That's why you get hypotension. And they talk about cytokine as well. So cytokine storm as well, as in the case of bacterial sepsis, and also in dengue shock syndrome, you talk about the similar phenomenon, cytokine storm. So what are the other manifestations of severe manifestations of leptospirosis? If you go by system-wise, the cardiovascular system, actually, Panduka describes some of these. The myocarditis is common, and you can they can come with arrhythmia as well. So in gastrointestinal system, the pancreatitis has been reported, and acalculous cholecystitis also have been reported. Neurologically, they can have internal intracranial bleedings and thrombosis. Actually, in Karapitiya, we found few cases of intracranial bleeding following severe leptospirosis. Aseptic meningitis is quite common and in early presentation. And hematological features like pancytopenia, autoimmune hemolytic anemia also have been described. Pregnancy can be complicated with leptospirosis leading into miscarriages. So, however, the high mortality is associated with when there is involvement of renal, pulmonary, or cardiac involvement. When these three systems involve, mortality invariably goes very high. So now, especially pulmonary involvement indicates that there is a high chance of leading into deaths. So in some instances, in some parts of the world, SPHS has become the leading cause of death in leptospirosis. And I'm sure that Sri Lanka also heading towards this. Now, with the importance of highlighting the importance of the new found entity, I'm going to talk to you something more about pulmonary hemorrhage. So I'm moving on to pathophysiology of pulmonary hemorrhage. This is a normal diagram of a normal alveolus, and this is a bit of a histological sort of descriptive diagram. And what happens in leptospirosis pulmonary hemorrhage is there is a linear deposition of immunoglobulins and complements on the alveolar surface of the epithelium, which causes direct damage to alveolar capillary membrane. So this is the most important area where this gas exchange occurs, the alveolar capillary membrane. The immune damage directly affects this most important part of the alveolus, leading into opening up of capillary and leading into the alveolar space. So that leads to pulmonary hemorrhage. Now, going into the initial management of severe cases of leptospirosis, as I told you before, severe leptospirosis is usually associated with a shock state. So you have to detect the shock state and diagnose it. You have to diagnose it and treat it. You can use IV fluid, but not like in bacterial sepsis. You cannot use IV fluids liberally, because you know that most of these severe cases of leptospirosis comes with cardiac and renal involvement, myocarditis and acute renal failure. So be careful in using IV fluids, and you can use noradrenaline as the choice of inotrope. Now, at the same time, during initial management, you have to do some monitoring as to whether the patient is going to develop severe pulmonary hemorrhagic syndrome. And you have to monitor respiratory rate, and you have to monitor saturation of this patient, and watch out for hemoptysis. If any of these signs or symptoms are appearing, that indicates that your patient is heading for severe pulmonary hemorrhagic syndrome. So if it is so, if the patient is moving on to severe pulmonary hemorrhagic syndrome, how we are going to manage the specific management of pulmonary hemorrhage? As I discussed before, alveolar hemorrhage occurred due to immune-mediated injury. And because of that, we can propose following treatment modalities. As Panduka described earlier, the immune suppression by using steroids, even though the results are a bit controversial, is one option, and we have been using it as a standard care. And immunomodulation is a newer way of tackling this problem. We talk about plasmapheresis, we call it therapeutic plasma exchange, TPE, or we can use IVIG, IV immunoglobulins. Or in the worst case scenario, we can opt for ECMO, but this, which is not freely available in the country, and also it is extremely expensive. So going into some of the details of therapeutic plasma exchange, it is relatively simple procedure, and it's widely available in the country, and it's cheaper when it compared with ECMO. And in the study we did at Teaching Hospital Karapitiya showed that the TPE, or the therapeutic plasma exchange, can be effectively used to treat SPHS. So what are the indications to start TPE, or therapeutic plasma exchange? Any three of the following in case of suspected or confirmed case of leptospirosis you can use as indication for the therapeutic plasma exchange. Tachypnea, arterial hypoxia, increase in demand for oxygen to maintain saturation. You start with nasal prong, and patient demand goes up, and you use Hudson mark, and then there is no improvement and patient needs some more, and you start NRB, and then perhaps ended up with CPAP. So if the patient is going in that direction, that means that, can you all hear me?
Yes.
Yeah. In that direction, that indicates that patients, there is something grossly wrong happening in the patient's lung. Very likely it could pulmonary hemorrhage. If there is a sudden drop of saturation, that is also an indication that patient is having a severe pulmonary involvement. Apart from that, hemoptysis is a clear indication of pulmonary involvement, and chest X-ray shows suggestive pulmonary. So with that, actually we use the therapeutic option to conduct our study, and we enrolled 62 patients of confirmed leptospirosis with pulmonary hemorrhage, and by using therapeutic plasma exchange, we managed to save 45 patients, achieving 72% of survival rate, which is very remarkable and which is statistically very significant. And unfortunately, 14 of patients whom we could not employ this therapeutic option ended up, actually they all died, indicating that in Sri Lanka, severe pulmonary hemorrhagic syndrome associated with severe very high mortality rate. Now this is the paper we published, and you can access this. And summary, leptospirosis has a change in clinical pattern, and SPHS is a recently emerged complication associated with very high mortality. It's a result of immune-mediated injury in the lung. There is enough evidence to confirm that SPHS is already well established in Sri Lanka. Therapeutic plasma exchange, or TPE, can be effectively used in treating these patients. Thank you.
Right. Thank you, sir, for that excellent update on various clinical presentations and management of severe cases of leptospirosis. Ladies and gentlemen, we are moving to the question session now. We have got a lot of questions. First, I would like to throw a question to Dr. Pandukar. So there's a question on prophylaxis for leptospirosis. What is the prophylaxis dose of doxycycline for leptospirosis?
Well, basically, to start with, you can use doxycycline. We can think of using doxycycline in prophylaxis in two situations. Some people recommend it for continuous use if you are, for example, farmers or someone involved with that kind of occupation where there's continuous exposure. In that situation, there was a Cochrane collaboration study, analysis as well, which showed that there is no value in doxycycline prophylaxis, and what is recommended there is 200 milligrams once a week. But that's based on about 3 different studies, but when the data were pulled together, there was no benefit actually. The other situation where you might think of that is when someone is accidentally exposed to the stagnant waters in a single discrete event. That is, for example, something like if you get caught in a flooded area, or if you fall into a stagnant water collection, or if you go to clean a well, abandoned well, a situation like that. So in those situations, of course, to cover that particular exposure, you can try chemoprophylaxis, and that's actually not prophylaxis. It's a case of what's called preemptive treatment. So in that situation, you can give 100 milligrams BD for about 3 to 7 days for that particular exposure, and then stop. And that has been shown to be effective especially after flooding. So that's basically the two situations where doxy can be used as prophylaxis. One situation is not very clear cut, probably not effective. Other situation is fairly good, and that's the dose.
Right. Thank you, sir. There's a question to Dr. Lilani about PCR testing. What is the best time for do a PCR in suspected leptospirosis?
Actually, I have given that in my presentation as well. That is the acute phase. Now, PCR will detect the DNA, and it is available only in the acute phase. So, when a patient present within 1 week, they can do the PCR testing, and the sensitivity will be higher in the early illness, that is, say, less than 5 days, and it varies off depending on the illness.
And there's an interesting question, madam. Now, Dr. Vimalasiri mentioned about the severe pulmonary hemorrhage syndrome. And there's a question asking any specific leptospirosis serotypes which causes pulmonary hemorrhage?
Actually, at the moment, I can't say, confirm, but there are a study is going on, and we are analyzing some of these data. So in Sri Lanka, but in elsewhere, they have said in Brazil, I think they have shown autumnalis to be more common in pulmonary hemorrhage than the others. But we are still analyzing our data. We have some cultures, actually Sajeev, Dr. Sajeev from Alpitia, he sent us some cultures, and we are doing a genotypic study on those.
Right. Now, when you analyze this PCR and serotypes in Sri Lanka, are there any specific regions for specific seros or any specific subtypes of lepto?
Actually, we are doing MAC analysis, that is serological. There are two types of classification for leptospira: serologic classification and genotypic classification. MAC will give you as a serologic classification. So we have seen in Badul, Uva province, there are much more autumnalis serova than in the other provinces. And this same thing has been shown by the animal health sector as well. In Badulla, they have shown autumnalis more than in other areas as well. Other than that, we haven't seen, different serovas for different locality. At the moment, presently, Tarasova is the commonest serotype in serogroup in Sri Lanka.
Right. Dr. Vimalasiri, there's a question for you. Now you were talking about pulmonary hemorrhages. This is the question about acute kidney impairment, the severe type. Place of IV methylprednisolone in case of acute kidney injury. And that's what they're asking. Is there a place for IV methylprednisolone for acute kidney injury?
I think Dr. Panduka answered this question. Actually, the use of steroids in severe leptospirosis, and the study done in Reddy shows that there is a positive evidence showing that the use of steroids in severe cases of leptospirosis is effective. But there are contradicting evidence coming from other areas, like for example from Thailand. the evidence is against that. I think over to you, Panduka, if you can elaborate on that, please.
Yes. Well, basically, I agree. I mean, if I can just go back to that slide, that might be. Yeah. So basically, let me share my slide with you. Then
Yeah,
I can. So the heterogeneous study used methylprednisolone IV and then orally. It was a case. It was a study where the cases were diagnosed not microbiologically, and also the control group was a historical control group, and they had a classification of severity from I think grades 1 to 6, I think, which was unique for that particular study. So that showed that there was efficacy for methylprednisolone in what they call severe cases, where the score was more than 4. On the other hand, if the Thai study, which used dexamethasone intravenously followed by oral prednisolone, that was in that one the cases were microbiologically confirmed, and it was a randomized control trial, not a historical control group. And basically, there was no survival benefit. There was also an increased risk of major nosocomial infection. So, on the whole, I think I would say that based on the available evidence, there's no proven value for glucocorticoids in severe leptospirosis.
Right. Dr. Emergency, there's another question about chest X-ray appearances. You said the ways of detecting suspecting pulmonary hemorrhages, and one way is by looking at the chest X-ray. So when you see these bilateral fluffy shadows, how do you say it's due to pulmonary hemorrhages itself? Can it be due to ARDS or LVF kind of? How do you differentiate?
There is a differential diagnosis coming into place actually. Now it could be ARDS as you said, and it could be something like pulmonary edema, severe pulmonary edema, because severe leptospirosis is often associated with severe myocarditis as well, and which can lead to heart failure and ending up severe pulmonary edema, which can give rise to a similar picture. And also conditions like, as Panduka mentioned, Hunter infection is a hemorrhagic pulmonary syndrome in Hunter. But now we have to be very practical in coming out of this situation, because you have to individually take these cases and think about. Now, for somebody to develop severe pulmonary edema of that caliber or degree, now patient should have other evidence of myocarditis. That is to say that patient should have significant ECG involvement, the ECG changes. And also if you do troponin, I have seen patients with coming with severe myocarditis, troponin going up to 50, even 80. So there should be troponin, positive troponin. And also if you can do a bedside echo, that will show a regional or global myocardial involvement. Without that sort of evidence, you can't just say that this X-ray is due to pulmonary edema. So we have to have evidence to come to that conclusion. There is no, there is no particular way of excluding that. But at the same time, you can treat those patients with available. If it is due to pulmonary edema, you can use diuretics. You can use something like CPAP if the case is very severe. So patient will improve on that. But if the patient, despite your diuretics and your other supportive care and CPAP and so on, so that indicates that something is different, right? So you can't waste time. That the time is very crucial at this stage. If the patient is developing evidence of severe pulmonary hemorrhage, the timely treatment would be very important. And secondly, if you are thinking of ARDS, that ARDS is a product of many insults. Actually, now when you talk about pulmonary hemorrhage in leptospirosis, which occur at the very early stage of leptospirosis infection, that is on the 3rd day, from 4th day to 6th day, more often patients develop symptoms and signs of pulmonary involvement, as well as chest X-ray finding will be there within that. But would you think that a patient who is coming with acute febrile illness with that short history would ended up having a severe ARDS features in chest X-ray without any other insult only because of the fever? So that is how we argue this case. Actually, there are no hard and fast rule to rule out these things. So the other thing is, in our study, we have seen similar sort of X-ray findings in our patients, and by using therapeutic plasma exchange, they improved. The X-ray became very much normal within a couple of days after plasma exchange. So that indicates that it is something, a condition which gives some results, which has some benefit. I mean, the therapeutic plasma exchange has done something on that and made the improvement. But whereas, as you know, ARD is not a condition like that. There is no benefit of doing plasma exchange for a patient with ARDS. And in the case of Hunter, actually, it's not a very common infection, and we have not seen many patients dying of pulmonary hemorrhage syndrome. But cases that we have discussed in Karapitiya most of the time, and actually with the help of Lilani, all the study cases were all the confirmed cases of leptospirosis. So probably we must have missed few of hantavirus cases. But I think the common things are common in our practice. So that is, practicing clinicians should know that, right? And leptospirosis come up higher in the list when the patient presents with this kind of X-ray. Then I think that is enough answer for your question. And yeah.
Right. Thank you, Dr. Emerging. And Madam Lilani, now we come to this Hunter. Do you have facility to diagnose hantavirus infection in your laboratory?
Hantavirus diagnostics are available in Sri Lanka, not in my laboratory. What I do is bacteriology. It's in the virology laboratory, and even the confirmation RT-PCR is available in Kandy Hospital.
So the sample sent for PCR testing leptospirosis and other leptospirosis related investigations, are they being subjected to this Hunter serology and diagnostics as well?
No. It's only It's what we do is leptospirosis diagnostics.
Right. Okay.
Only for research studies we do Hunter, but for service we do only leptospirosis.
Right.
GANAKA,
yes, sir.
Can I just say one thing about the pulmonary hemorrhage, that the question that you asked earlier? Luminary has seen a lot more cases than I have, so maybe he can confirm whether this is helpful or not. One clue that it's a pulmonary hemorrhage in lepto is a very rapid progression. For example, if you monitor the patient, things like the respiratory rate and the saturation, you can see the patient deteriorating every hour, more or less. So the tachypnea and the desaturation happens as you watch over a period of a few hours. On the other hand, things like AKI or LVF producing volume overload and pulmonary edema will take a lot more time than that, because you need that volume to be collected in the lung as fluid, and it will be not a few hours anyway. So that's an important tool. And of course, also the fact that often there's hemoptysis also, especially if it's a very severe case. I mean, Luminary, you might be able to.
Yeah, you're absolutely right. You're absolutely right, Panduka. Because as the patient develop pulmonary symptoms, we can see that within minutes, patient deteriorates and ended up in respiratory distress, needing ventilatory support even, right? So that is a matter of minutes rather than hours. So the patient, the clinician who have managed these cases would know how rapid the progression is. So in that case, no point of arguing or contradicting or discussing about the differential diagnosis. That I think the available evidence in that context propose that the possibility of leptospirosis pulmonary hemorrhage, go for it. Yes.
So the message would be to look at the X-ray, but always look at the patient as well, isn't it? I mean,
yeah, you are absolutely correct saying that. So you have to take the whole picture. You have to get the patients as an individual and take everything into account, because this is a difficult diagnosis to make anywhere in the world, not only in Sri Lanka. So PCR tests won't be available within a matter of hours, and the MET confirmation will come after at least a week after. So you can't waste time on looking at the X-rays.
right. Dr. Imersiri, how easy to arrange this plasma exchange?
Actually, now you need to speak to the transfusion physician if available. I think transfusion physicians are available from base hospital upwards. So you can speak to transfusion physician. They are more thorough with this procedure, and the equipment are also available in most of the major hospitals, I think in general hospitals and teaching hospitals. So you can refer those patients where it can be done if you are working in a base hospital. And also, expert advice can be taken from our own transfusion physician. She's Vishanti Galivitiya. Actually, she has done more than 300-400 therapeutic plasma exchange, not only for leptospirosis, she's doing for many other causes, conditions as well. So she is very experienced, and you can straight away contact them and arrange this.
Right. Thank you. And there's another question for you, sir, Dr. Panduka. I think you have mentioned this in your lecture too. Any benefit in combining doxycycline and benzyl penicillin / third generation cephalosporins in moderate to severe leptospirosis cases?
No. You can use benzyl penicillin or a third generation cephalosporin, but there's no need to combine it with doxycycline.
Right. Thank you. And Dr. Imersiri, now you have conducted trial on this pulmonary hemorrhages and therapeutic plasma exchange. Are there any similar trials done in the world, anywhere else?
Actually, the literature says that there have been few cases of case reports in relation to use of therapeutic plasma exchange, but in most of the developed countries, what they use is ECMO, which is more sophisticated and more expensive therapeutic procedure. There are so many case reports coming from the developed world saying that the effective use of ECMO in severe pulmonary hemorrhagic syndrome. But in a country like Sri Lanka, ECMO is there is only one institute that is teaching us Karapitiya. The ECMO is available, and it's not practical to use this wide over the country. So there are case reports only with regards to plasma exchange, but there has been a small study conducted in India using plasma exchange, and where they have actually picked up only the milder cases of pulmonary hemorrhage. So their conclusion was not enough evidence to support therapeutic plasma exchange, because there had not been any deaths, many deaths even in the control group. So their criteria for inclusion was there has not been much of severe cases for them to do this study.
So that means as Sri Lankans, we do have lots of severe cases. We need to get into the culture of studying them, isn't it, Dr. Imersiri?
Because I have seen only in Brazil and some other East European countries like Vietnam and Thailand is coming out with reports like us with severe pulmonary hemorrhagic syndrome. Not even in India, this is not a severe problem in India. If I go back to my first slide, showing that the global incidence, the world map of leptospirosis, Sri Lanka is one of the countries with one of the highest incidence of leptospirosis, and same time we have the highest, I think, number of complications as well. So it's time to wake up.
Right. I think we have taken a couple of extra minutes because we've been getting lots of questions, to be honest. I think we have answered many, but we are running out of our time now. I believe we have to conclude this webinar now. Let's conclude it by getting the most important message, take-home message from all our resource persons. So may I invite Dr. Panduka Karunanayaka. Sir, please tell the most important message to this audience in 1 minute.
Thank you, GANAKA, once again. So yes, I think the important message is we need to understand or realize that the epidemiological picture of leptospirosis is changing into a different one, from rural to urban, from occupational exposure to environmental exposure, and so on. So we have to have a greater awareness or suspicion of leptospirosis than before. And at the same time, there are various atypical manifestations of leptospirosis, not just the jaundiced one. That the older traditional teaching of icteric and yellow and bleeding conjunctiva is no longer enough, and even anicteric ones can become very severe and even die because of these unusual atypical manifestations. So all this means that basically we have to quickly get laboratory confirmation of leptospirosis. We must suspect it widely and confirm it laboratory-wise, because there are no clinical features that you can't diagnose some clinical features alone. And fortunately, all the laboratory tests that are necessary are already available in this country, so we have to get into the stride of using them. Sending off a sample for leptospirosis in the first few days of the illness, maybe day 2, day 3, or day 4, and getting the report back in about a day or two might be enough for you to be ready to pick out the early pulmonary syndrome as it happens around day 5 or 6 or whatever. So I think that's basically the main message that I want to give you, and also to tell you that the important antibiotics are benzalpenicillin, cefotaxime, and ceftriaxone, and try to use this as far as possible if you're suspecting leptospirosis, even in combination with other pathogens. Thanks.
Thank you, sir. Madam, it's your turn now. Please tell your most important message in 1 minute.
Thank you, GANAKA. My message is that laboratory confirmation is available for any stage of the disease in Sri Lanka. So please use this optimally to diagnose your patient or to confirm your patient. And I would like to say about the cultures, even though the culture is not useful for the individual patient, if you send a culture, that will tell, I mean, that we will know the disease burden and disease. We can describe leptospirosis in a Sri Lankan context. So also, when you are sending, these are all very special tests. So when you are sending your specimens for leptospirosis diagnostics, please send a short clinical history, please. So also, actually, all these tests are available for private sector as well for a nominal fee. So
Right. Thank you, madam. Dr. Emergency, it's your turn. Please voice out the most important message in 1 minute, please.
Yes. There are enough and more evidence to say that severe pulmonary hemorrhagic syndrome is in Sri Lanka, and it has been in our backyard, and we have not recognized it actually. And we have been arguing about when you see a X-ray, as I mentioned before, about various other complications or various other conditions, rather than concentrating on this condition. Now it is there, and we have the evidence, and it is killing our patients, and it has a very high mortality rate. Be watchful. You can detect these patients and you can treat these patients. And if you are watchful and ready, you can save lives. That's all.
Right. Thank you, Dr. Emergency, for that message. So on behalf of our President, Professor Tilak Jayala, and the Council of Sri Lanka College of Internal Medicine, I would like to extend our profound thanks to Dr. Pandu Karunanayaka, Dr. Lilani Karunanayaka, and Dr. Emergency for your continuous dedication and commitment to this field and for participating in this webinar today, sharing your valuable knowledge with all of us. Thank you ever so much for our participants joined locally and from overseas. We got about around 300 participants today. Thank you for joining in numbers, for your attitude towards learning. And very special thanks should go to our partners today, Dr. Reddy's team, Mr. Prasad, the country head of Reddy's, and Mr. Wasim, the brand manager of Reddy's, and their team. Thank you very much. At last but not least, Mr. Anton of Luminary Learning Solutions, who is our technical guru for a job well done behind the screens, Anton. Thank you very much. And I hope we all were able to gather new knowledge and brush up what is already known about leptospirosis and its clinical management. This will immensely help to combat emerging burden of leptospirosis during this COVID epidemic. And I sincerely believe this webinar would help Sri Lanka College of Internal Medicine to achieve its goal, which is none other than to deliver best possible care for our patients. And once again, thank you very much for joining with us. Good night.